thankful to have her as our hospice lead on our advisory board for LOCA. And for those of you that were at our last meeting, our last General Assembly at East, Dr. Greenstein was awesome and very flexible as we ran over time there. So we wanted to make sure she got in early. So she's going to give us a little presentation and education on how to keep your patients out of the hospital. Please welcome Dr. Greenstein.
Thank you, Nick. So nice to see everyone again. And so this is a nice follow-up to what she had a couple slides up there about readmission rates and how that is so important, that we want to lower those readmission rates at the hospital. So that's kind of what I only have 6 slides, and then we'll have some time for discussion afterwards if you have questions. But you know, hospice is a wonderful Medicare hospice benefit, and it is a way to keep patients in your facilities, even if they have acute symptoms. And it's a way to get them from going back to the hospital and then helping limit those readmissions. Thank you. So in hospice, there's 4 levels of care. Most of your patients that you see that are on hospice are on routine level of care. So that patient is on hospice and they're terminal, but they're in a sense not in crisis. So you're getting a nurse visiting once or twice a week. You have a home health aide, your social workers visiting. These are all guidelines set by Medicare. And these patients are on this level of care. Now, there's 3 other level of cares that hospices are providing. One is respite, one is crisis care or continuous care, and the other one is general inpatient, which is GIP. So all hospices under the hospice Medicare benefit should be providing those 4 levels of care depending on the patient's needs. And then the hospice and Medicare is paying that hospice based on that level of care. So they're not paying the hospice per patient based on their diagnosis. It's all on their level of care. So there's a set amount when they're on routine level of care. When they're on crisis care or general inpatient, the rate goes up quite a bit more because that hospice is providing more. They may have a nurse sitting at bedside during that time. So continuous comfort care, we'll start with that. That can be done in a home, assisted living facility, or a SNF. The hospice provides a minimum of 8 hours in a 24-hour period. Now, there are hospices that like to cover 24 hours so that the nurse is always there at bedside monitoring the patient. But Medicare really requires a minimum of 8. And it doesn't even have to be 8 hours in a row. It could be like 4 hours in the morning and 4 hours at night, but it has to be by either an LPN or an RN. The care is primarily nursing care, so not custodial. So unfortunately, it's not that the patient is tremendously anxious and they keep getting out of bed and we need a sitter. So Medicare isn't going to allow that hospice to put a patient at bedside to keep that patient from getting out of bed. Now, if that patient is trying to get out of bed because they're in pain or they're having terminal restlessness in the dying process, then yes, they may meet criteria for crisis care where a nurse can go at bedside and try to medicate a little bit. We use medicines like Haldol possibly to keep the patient, works exceptionally in terminal restlessness, Ativan, and if the patient's in pain, pain meds, right? So, but that Medicare is paying that hospice a lot more money now because they were placed on a higher level of care. So that nurse has to have the documentation to support that higher level of care, which turning a patient only or redirecting possibly is not going to meet that criteria. Okay. So I want you to understand that when you get possibly pushback from your hospice that no, we can't put a nurse at bedside for that reason. Okay. Another higher level of care, remember there's two higher level of cares, is our GIP. Contracted bed paid by the hospice and staffed by the facility. Okay. So those are things that you contract with your hospice to have a bed. Now, the hospice helps in addition. The hospice provider will make daily visits to direct care, but it's your staff that are providing the bulk of the care in those situations. So when do we use these higher level of cares? Okay, it's a period of crisis, which is defined as a time when the individual requires continuous care to achieve palliation or management of acute medical symptoms. They can be new symptoms, or they can be an exacerbation of chronic symptoms. So give me a couple examples of what could be a crisis in a patient, in a hospice patient. Pain, right. So you may have a patient that all of a sudden has increased pain. They may be on for cancer, and now that hospice is trying to manage that pain. Maybe they have changed pain meds and possibly have started methadone. That is a great opportunity to put a patient on a higher level of care, because we need to watch a patient being placed on methadone because it has a, different type of half-life that requires being able to watch and make sure that we don't have any side effects that are going to cause respiratory depression and things like that. Or they could be a patient that has stopped swallowing now, and now we have the only pain med we can use is morphine. Comes in a liquid form, but it also has many benefits vascularly to keep oxygen getting everywhere, helps with anxiety and shortness of breath. What's another example of a crisis? Hallucinations. And we may see hallucinations because why? Yes, they're transitioning, or
I said they're dying.
dying, yes. Or they have acute delirium, right? They have a UTI or pneumonia. And so they're hallucinating. A lot of older people don't mount a fever. So we don't know they have a UTI. We just know it because they're all of a sudden like talking to, dead people, and they're picking at the air, things like that. That's a crisis. Family walks in and is like, holy cow, what happened to mom, right? So my son would always say to me, Mom, you're a hospice doctor. What do you fix? Or what's an emergency? Why are they calling you? I'm like, honey, if a loved one or somebody taking care of somebody walks in and a patient is trying to climb out of bed and is at risk for breaking their hip, that's a crisis. Okay. Next slide, thanks. So these are other examples. New onset pneumonia. During COVID, we had patients who had COVID, and we put them on crisis care to be able to get them through COVID, hopefully, get them to the other side of that. Intractable nausea and vomiting, uncontrolled pain, we talked about that, delirium, restlessness, uncomfortable transition to death. So the reason I underline uncomfortable transition is, unfortunately, the hospice Medicare benefit does not pay a hospice to be there for a comfortable death, right? So Hollywood always depicts a very comfortable death, right? And we do see patients who just stop eating. So we're not feeding them anymore, discontinued all their scheduled meds. Their respiratory rate is 16, normal. Their heart rate's normal. They're not in pain. It's the way we all want to go, right? We can't sit there and get paid a higher level of care because we're not medicating the patient. They need to be turned every 2 hours, but again, they're in a facility. That's what you guys do, right? So we unfortunately can't be there when a patient is dying peacefully. Now, a lot of hospitals will put them on like imminent status, and their visit frequency goes up. They're now going to see that patient every day. They're going to bring in more resources, like the chaplain's going to see them, social worker's going to see them, and the nurse, the medical director, like myself, may go and see them. So they get more visits, but they're still on routine level of care. They don't meet the criteria for crisis care. Some hospices also have like a vigil volunteer program where they have volunteers that will sit with the patient so that the patient, if they have a gap where the family can't help, maybe the vigil volunteer can be there just so the patient isn't at risk for dying alone. Okay. And all hospices do this differently. So that's why it's always important to, have your patients interview hospices and ask these questions. COPD and CHF exacerbation. That's key. And that's the next part of this lecture. So these higher level of cares are intended to be brief. Daily reevaluation of the patient's crisis and impact on ongoing interventions. So as medical director, I will go when a patient's on a higher level of care and make sure that patient every day meets criteria for crisis care. If at some point, we've put the patient on scheduled morphine, maybe every 6 hours, and they're doing fine, and they fall into that really peaceful Hollywood patient of dying, I need to DC crisis care and put them on routine level of care. So it's a 24-hour thing that needs to be reevaluated. And I need to make sure the documentation supports that. So it's a physician's clinical judgment, or NP, when they come visit, hopefully daily. Once symptoms are stable, patient returns to routine level of care. Patients can move back and forth. So I've had patients on crisis care where I got them snug as a bug, they're dying peacefully, but then all of a sudden their respiratory rate goes up because they're hitting the next point of their transition. I can, with a phone call, put them back on crisis care. So they can go on and off the level. They just need to be appropriate to the level they're on. So they can move back and forth from routine level of care to crisis care depending on symptoms. We talked about dying does not always meet criteria for higher level of care. Once crisis symptoms of transitioning are managed on CC, patient may need to return to routine level of care. All right, so going back to how do we keep these patients out of the hospital? Patients, in particular, COPD and CHF have what? Frequency of what? Readmissions, exacerbations, right? Anxiety. So when these exacerbations occur, if the patient's on a hospice, that hospice can do a higher level of care instead of calling 911 and moving the patient out to the hospital. Because most times patients with end-stage COPD and end-stage CHF or any cardiac disease are already on maximum medical therapy. So they go to the ER, they're not getting any new medicine, except probably morphine, right? Because they're short of breath, they're anxious. Morphine is a vascular med. It's been around since the Civil War. It's how we got our soldiers off the field, salvaged limbs. It helps the whole body utilize oxygen better. So I know a lot of people are afraid of morphine, but that's why we use it at end of life. We've had patients who are modeling at end of life. The morphine takes the modeling away briefly. Of course, it's not going to stop them from dying, but that's how valuable it is. So anyway, instead of them going to the hospital and getting morphine, breathing treatments, maybe Lasix, or, they can't probably adjust their oxygen too much because they, will get CO2 retention. So they're not really doing anything different than putting them on a higher level of care. And so these higher level of cares can be utilized, keep the patients from bouncing back to the hospital, keep the hospital readmission rates down, and keep your beds full, right? And the last thing you guys want, as you've been taking care of Miss Smith down in the hallway on the right, is for her to die in the hospital. And you weren't there to be part of her end of life. But that's what's going to happen, right? One of these exacerbations, because every time it happens, are they going back to their baseline? No. This is a perfect trajectory of patient being hospice appropriate. If they go out one time to the hospital and don't come back to the same baseline, they're starting to be hospice appropriate. So one of these exacerbations, they're going to end up in the ICU on a ventilator, or they're gonna die there or in the ER. And you're not gonna be there to be part of that. And the family, obviously is gonna be very distraught. So I could put up the same trajectory for CHF. It would look very similar. All right, so that's all I had. I didn't know if there's any comments, questions, or input.
Dr.
Yes.
How do you suggest we best educate at least the nursing teams that we have for all of our different companies?
So it's really getting an in-service like this. If a hospice can get in front of the case management team, the nurses at facilities, they need to be able, even the aides, everybody is part of taking care of patients. And you have aides that are going in and doing daily care. And they are now, the patient didn't need oxygen when they took a shower. Now they're tethered to their oxygen in the shower. That's a hospice appropriate patient. So it's just education and, and obviously that's my love. So, anytime, we can get in front of nurses, case managers, physicians, nurse practitioners, PAs, social workers, physical therapists, they're seeing patients and doing physical therapy, and patients not doing well in physical therapy. Anything else? Yes. This is my boss, so I gotta answer this right.
So are the 4 levels of care a requirement for you to be a licensed hospice?
Yes, they are. So Medicare requires all 4 levels of care to be done by the hospice. So that's why it's just important for you to, have your families or research yourself what hospices do the 4 levels of care. Because the last thing you want, and we've seen it, is that a patient goes into crisis and they have to switch a hospice because that hospice doesn't do a higher level of care. And, and we've had examples of that, and it's so hard, right? And then we get the patient and they die in 24 hours. And so we don't feel like we even connected to them. So, yes, bro.
This might be silly, but have you seen an increase of people using death doulas?
I just read an article in People magazine about death doulas, but I was not happy with this particular article because they said that hospice does not do death right. So, but yes, I have not seen it here in Central Ohio so much. I think, in California, those new game changer places. But the other thing is there's no reason they couldn't have a death doula and hospice.
Yeah.
Right. And the article I read in People was they did everything. But meanwhile, that hospice wasn't involved. And so you have to remember that one of the greatest benefits about the hospice care benefit is the bereavement that family gets for a year after that patient passes. That's a mandate. And so that family is getting phone calls, they're getting letters, they're invited to support groups. So if that patient is only on that hospice for a tiny bit of time, and it was all crisis from start to finish, do you really think that family's gonna really reach out for that bereavement? Because they didn't really get to know the social worker or the nurse or the chaplain. So the bereavement is a huge piece. And I know we gotta go, right?
I just had one question, because I think what we see here is that patients that are on hospice, they do suffer some type of a acute event, exacerbation. They retract hospice, come back to the hospital. So that's where I think, how can we take steps to mitigate that, or what is done with the family, because they panic, right?
Yeah.
Their loved ones going into an exacerbation.
Right.
Done. We don't want hospice anymore and send them back.
Right. And I think a lot of times they get into that thing, they had an exacerbation, the hospital fixed them, and then they came back. What they're not seeing is this.
Right.
So they need to be educated that they're not coming back to baseline. So now your mom needs help. She needs a bed bath now. or she needs her oxygen in the shower. You know, so we need to tell them that, yes, you came to the hospital, but we didn't fix you. You're actually lower than you were when you came, you know, last time you were here a month ago. And so that's education. And then, you know, obviously the social worker and the nurses of hospice are always working with the code status, you know, and I've been around long enough where there was a DNR and a full code. That was it, right? And now we have the DNR-CCA, which is very wishy-washy, right? So, and we work really hard to try to get people from DNR-CCA to full code, because at the time of crisis, you guys in facilities are saying, what do you want to do? What do you want to do? This is your time. Do you want to be CC or do you want to be DNR? And, you know, depends on the education of the family and the patient of what they choose. It's a good question.
I'm Valerie, nurse practitioner, and I would just say I've run in several facilities, and I think going back to your facilities and doing an education and service is probably the best thing, because if the nurses are telling me sooner that, hey, Mrs. Smith's in the, you know, shower with oxygen, if that's not getting back to me in timely stuff, I'm not gonna catch it. So I think just having, even just the education that she just did was enough to really open the eyes of the aides, the nurses, the NPs. So then that we can do that education piece and discuss with the families, hey, we're gonna be able to do the same thing. Let's just call hospice. Let's take care of it right now. And I can go ahead and add the morphine if I need to right then, or talk to hospice on the phone and say, hey, let's do this. But I think that's the big thing, is just that education piece and making sure all your staff are getting this education.
Thank you,
I'll jump
Lisa.
in real quick. So we do record our session. They do get published on our website. So in the event that you want to be able to watch Dr. Greenstein's presentation with your team, you'll be able to do that by just going and look it up, or scroll to the bottom, that's the homepage. You'll be able to see that video, and I'll see if I can make it where we break them out and you can look at just that part instead of watching the whole thing.
All right,
Thank you.
thank you.